actually heading to the last session of this summit, not just the day. And I'm almost feeling like, we need to keep going on. So let's look for more ways to keep it going on. So on the screen, you can see our co-president, Ken Masson, is on the screen. He's live. He will be moderating a speaker session on the lymphatic filariasis at the brink of elimination, yet still a challenge. Clearly, I need to work on that pronunciation. My apologies. I only came to know about this particular condition when we were discussing the plan for the summit. So if I was to give an introduction to our co-president, Kenneth Masson, I know my words will be too short. He is the founder of this very Rotary Club of World Disability Advocacy. This has been his lifelong dream. This is where he leads global initiatives like this one, advancing disability rights, inclusive health systems, and equitable access to opportunity. Based in Colombia currently, but originally from the US, he is connected to networks across more than 40 countries, and he also serves as the chair of Rotary Disabilities Advisors and Communications Chair for PPS Advocates. Ken is known for mobilizing international coalitions, shaping high-impact outreach campaigns. With a background rooted in nonprofit leadership and global service, he brings a strategic, communication-driven approach to strengthening disability inclusion worldwide. As I said, I know my team will agree. These words do not do justice to who he is. He is the backbone of this very Rotary Club. He is an inspiration to each and every member, board member, executive member, and friends of our Rotary Club. Ken, we are honored to welcome you into the session that you will be moderating. Thank you so much once again for all your support. Thank you.
Thank you very much, Sonia. I apologize for my headset here, and because the speaker in my computer and my microphone is very poor, but this is what we do. We adapt to situations. So my headset is my adaptation so I can be inclusive here. And it's my pleasure to be moderating this very last session of this two-day event. And it's my pleasure to introduce to you Dr. John Ehrenberg. Dr. John is a retired World Health Organization director for communicable diseases in the Western Pacific. He's got 40 years of global experience across research, academic, and public health. He has led major international programs, built multi-sexual partnerships, and mentored professional worldwide, active in conservation work in Yucatan, and a consistent advocate for One Health and NTD prevention. He's published regularly on disease control. He's currently chaired the External Review Board of the Swiss Tropical and Public Health Institution, and promoting global North-South collaboration. Doctor, we could go on just for a whole day introducing all your credentials, but I've tried to summarize them a little bit. Welcome, Doctor. We are very much looking forward to this presentation and learning about this disease. It's a disease, is that correct, Doctor?
Thank you very much. Yes, it's a disease. First of all, let me check. Do you hear me?
Yes, sir.
So before I get into the actual core of the presentation, let me just go through some rather fascinating information, bits and pieces of information. It's almost like a National Geographic special. And so let's go to the next one. So I got to give credit to some of the people that were intelligent enough to and patient enough to be able to sit down and discover the causative agent of these infections. These infections affect about 120 million people globally. So it's really not a minor disease. It's not a minor infection. It's a disease of the poor. Several people have mentioned the issue of lack of equity, of poverty, and unfortunately this, as well as many other diseases, and to some extent also the disabilities that they cause, are problems of the poor. They tend to be usually concentrated in what we erroneously call the global south, because we have countries such as Australia and New Zealand that are in the global south, but it's really, I'm referring myself really to the developing countries, tropical belt, subtropical belt, developing countries where there's some really, really extreme poverty issues. And so some of these diseases really affect the very poor for some very logical explanations. So very quickly in this slide, between 1866 and 1965, so merely 100 years, several very notable scientists discovered the 4 causative agents that cause lymphatic filariasis. And on the left is a small picture of the baby of this parasite. We'll get into that on the next slide, on the next couple of slides. So the next slide, please. The next slide shows you some of the conditions. I hope you can see them. I mean, I wish I could have the broader screen, but the next slide basically shows you the conditions that some of these people live in. And this is a fairly well-to-do city, Maceió, in the northeast of Brazil.
There we go.
So that's right, lovely. I don't know what I pushed when I did the PowerPoint presentation, so it gives me this effect of winding down and up and down. I hope that will wake up people if, in the event of my presentation, some people fall asleep. But anyway, this is a typical disease of people living in conditions of poor sanity and hygiene. There's you can see an open canal here of drainage system, and that is one of the places where one of the species of mosquitoes loves to breed. So people live close by, live next to these things, and in many countries throughout the developing world, you will still see some of these open drainage systems where people wash, live, throw their garbage, and get infected. The next one, please. This is a culprit. It's a worm, but we call it filariasis because it comes from the Latin filus, which means thread. These are very, very thin worms. The adult worm is on the left. The females are 8 to 10 centimeters, so it's quite large. And the males are 3 to 4 centimeters next to it. They're smaller. And on the left, on the right, you have the baby. That's what we call the microfilaria. And these are fairly small to the point where you cannot see them with your bare eyes. You have to put them on the microscope. They're up to 300 microns. A red blood cells measures 7 microns. So this is a good magnitude, larger than a red blood cell. But you must still watch it in the microscope. The next one, please. And this is the vector. It's like the little plane that transports the parasite between one host and the other. Think about the beauty on the one hand and the amazing natural history story of an organism, the worm, that requires 2 hosts to be able to survive and complete its life cycle. It lives on the one hand in the human host, but it can also be an animal host. And then the parasite needs to be transported to another host, to infect another host. And for that, it uses a very clever mechanism of picking up a mosquito, having a mosquito pick it up. And here you see one of the mosquitoes that transmits the infection as it's biting a host, a human host. It's an arm. And on the left, you see the 2 mouth parts of this mosquito called proboscis by the entomologist, where you can barely see the little microfilaria escaping from the mouth parts. And when these are injected into the human host is where they're going to cause the disease. So this is when an entomologist watches a microscope, dissection microscope of the proboscis of the mosquito, it might see these microfilaria emerging through the mouth parts. You have 4 different genera of mosquitoes. And why is this important? because either of these genera mosquitoes, Culex, Aedes, Anopheles, and Mansonia, have slightly different ecological requirements where they live, breeding sites. On the one hand, you have Culex, which breeds in very highly contaminated canals. Aedes, you may remember Aedes aegypti from dengue, chikungunya, and Zika that affect a lot of people in developing tropical countries, but it also transmits dengue, Zika, and chikungunya, as I mentioned before. Anophelines, which are one of the key vectors of malaria, but they can also transmit this infection, and the Massonia. The next, please. In the next slide, you will see, for example, on the left, a typical breeding site for Culex, an open drainage system. And on the right-hand side, you see a much more lush tropical area of a lake next to swamps where you have water lilies and hyacinths growing. And Mansonia likes these rather cleaner environments to survive and to breed. The next one. The next one is a very schematic representation of biological life cycle, but you can understand it very well. On the left one, you have a man, a human being, with a little circle around the leg, inguinal node, and that's where the adult worms live. They live in the lymphatic system. And that is where they produce a great deal, or where the great deal of the damage that is caused to the person is really created. And then it jumps very geniusly. It produces a babies and microflora, which move from the lymphatic system to the venous and arterial, but basically to the blood system. And over there in the superficial vessels of the circulatory system, it will be picked up by the mosquito. In the mosquito, it will undergo several stages of development into an infective microflora that will be injected again upon feeding on the next victim. And there it will migrate to the lymphatic system and evolve and develop into an adult worm. So this is the life cycle. The next one is basically the same. Forget about the right. This was a CDC scheme. But on the left, you see the adult worms and what they look like. On the left is a female, and on the right is a slightly smaller male. The female can live up to 8 years, and the male, the microflora, up to 1 year. This is, the male and the female up to 8 years, and the babies can live up to 1 year. This is critical for the epidemiologist to understand the life cycle and to also understand how evolution has worked to develop, to give the parasites a certain advantage in order to be able to survive between different hosts. The next one. I think this is an incredible and marvelous, it takes decades for this evolutionary process to have taken place to finally get to this point where you have this life cycle. The next one. By the way, it's not unique to the filarial parasites to have these unique life cycles. Many parasites, be these worms, be these bacteria or viruses, or even fungi, require very complex life cycles very often. They will require intermediate hosts or even secondary hosts to survive. That means that they have adapted over the course of millennia to one host where they may cause damage, to the next host where they will continue their development, and to the third host maybe where they might complete the development before infecting now another host and cause disease in that other host again. I mean, you just have to picture this in your head and see how incredible evolution has been. In this slide, again, something very, no, the previous one, sorry, Ken. The previous one again is the previous, up there. Next, down there, previous, there you go. The previous one shows you how these microfilariae in the bloodstream move towards reaching basically the most superficial blood vessels in the skin, and how they do this during the day and all the way up to the middle of the night. These are two curves, one for the actually observed one and one a theoretical curve of what we call the periodicity of the microfilaria. And it's been so cleverly devised by this worm that the adult worms produce a maximum number of microfilaria in the middle of the night, which is where the peak of the biting habits of the mosquitoes take place. This is where the mosquitoes really have their peak biting hours, between 10 o'clock at night and perhaps even 11 or 12 or 2 o'clock in the morning. That's where the mosquitoes bite the most. Why do they do that? Because usually animals, humans included, sleep during that time of the day, and they're less likely to squash the mosquitoes when they're biting. So they have a greater chance of surviving. And the worm adapted to that, to the habits of the mosquitoes. Can you imagine that? The next part. This is where the infection is distributed. You can see across all continents, from the basically tropical belt, from America through Africa to Asia and Southeast Asia. The next. In America, you will see you used to have 7 endemic countries. Fortunately, now you only have 3. But look at the scandalous figures on the right-hand side. Haiti has a population at risk of 6 million. And a population at risk means that these are people living in areas where you have cases. That is, you have the worm living in people. You have the mosquitoes. You have the proper environmental conditions that allow for the mosquitoes to breed. So you have all the external factors and intrinsic factors that allow for the people to be infected if they get bitten by an infected mosquito. So this is the at-risk population. In Haiti, it's 6 million. That is 70% of the population. 1.7 million people actually are infected in Haiti. The Dominican Republic has 50,000 infections, reported infections. And I'll tell you this, usually reports are usually underestimates of the actual figures. That's just the way it is, and more so in developing countries. And in the Dominican Republic, you have a population at risk of about 88% of the population at risk, which is considerably smaller than Haiti, which is right next to it. And so it tells you a lot of things. We get a lot of information from these data in terms of availability of healthcare systems, in terms of migration of people, in terms of et cetera, in terms of the environment itself. We reached the last one, which is Guyana in South America. They too have 50,000 recorded infections, but they have 84% of the population at risk. There's 600,000 people at risk because their population size is awfully smaller, but it's still an enormous amount of population at risk in that country of still becoming infected. The next one. How do you pick up the infection? Very cumbersome in many ways. You have to pick them usually, and you've been doing this for decades, in thick blood smears of blood. I mean, basically, you take a finger prick and you take a drop of blood, you spread it over a slide, you stain it, and you visualize in there the microfilaria. You need to do it under microscope. The second important one has also been around for quite a while, is in concentration methods by filtration. That is, you suck up blood and you filter it through a special membrane, which you then will stain and look for the microfilaria itself. More sophisticated techniques are the more recent one, which is a detection of antigen in serum. It's very, very similar to the pregnancy tests, where you basically impregnate the strip with an antibody and you throw a drop of blood on top. And if there's antigen of the parasite, it will bind to the blood, and that strip will become visible, very much like a pregnancy test. Antigen means any foreign particle inside another organism, and is basically material that is shed or secreted or excreted by that organism or foreign particle that becomes basically an antigen within that person when it's inside a foreign person or a foreign body or foreign organism. That's an antigen. So normally when you have an antigen, that means that you do have the parasite, it's there. All 4 methods will detect a living organism inside the human host. The last one is a much more complex one because it requires ultrasound, and that will pick up adult worms in dilated vessels, lymphatic vessels. You will actually see the adult worm moving very actively, and this is what the parasitologists call the filarial dance. The next one. Just think about now slowly in terms of the logistics involved in picking the infection that will ultimately cause all these disabilities. You're required to pick up blood, to take the blood samples towards the middle of the night. That is, you work between 10 o'clock at night and sometimes up to 2 o'clock in the morning. And usually you find young volunteers, or what I call victims of the system, that will work for free very often. You might even find community workers that will do this, and they will be trained to visualize the slides under the microscope to find the microfilarium, and then estimates the microfilarial prevalence rates and basically prevalence rates that you will need for your programs, for control programs. The next one. And the next one is basically what you see under the microscope. On the left, you will see the filaria, which is one of 4 types of filarial parasite. The majority of filarial parasites are caused by this parasite called Rotary bancrofti, after 2 of its discoverers. And it's a tiny little 300 micron, up to 300 micron worm that has, it's beautiful when you stain it, it's quite beautiful. It has all these nuclei inside, and these tail nuclei is what you use to differentiate microfilaria from different species of parasites, of other filaria. So in the case of Brazil, you have another filaria coexisting in the areas, which is Mansionella osardi, looks very similar. And the only one you can differentiate them in blood smears, sorry, is by counting the caudal or the tail nuclei in the tail end of the little worm. That's how you differentiate them. Mansionella osardi is present in animals, causes disease, may cause disease in animals. Fortunately, it doesn't cause disease in humans, but it can actually infect humans and can be actually picked up and be confused with Rotary bancrofti if you don't have a trained eye to be able to look at the nuclei at the end of the microfilaria. The next slide, please. This is an ultrasound that you take, and for this, obviously, you can't do this really in the field. You need to go to a health system where they have be able to do the ultrasound. And here's a lady taking an ultrasound in the scrotal region, inguinal region of a patient. And what you hear is a picture of a dilated lymphatic vessel. And when it's a live thing, you see the animal, the parasite moving inside, which is what I said before, the filarial dance. This is a way of confirming that you have active living parasites inside a person. The next one. So the goals of this elimination program is everybody gets treated by drug mass administration with either one or all 3, or some combinations of either one of these 3 drugs: ivermectin, diethylcarbamazine, and albendazole. The treatment scheme is once a year for at least 5 years. Think about that. You're treating thousands and thousands of people with a desired coverage of at least 65% of the total at-risk population. Remember what I said about the at-risk population? It's a huge amount of people that live in areas where there's a risk of acquiring infection. So you have to treat at least 65% of those. That involves very careful field work, doing surveys in the field, interviewing people house by house, taking censuses, et cetera, et cetera, et cetera. So it's a real logistical challenge to do this. And elimination is reached when you can get below the level of 1% of antigen prevalence. That is, less than 1% of the people you examined have less than 1% of microfilarial rates, and that's basically the cutoff points below which you would have interrupted transmission. And of course, if you have the advantage of doing vector control, to control the vector themselves, the mosquitoes, you can either use larvicides. Normally today you use pyrethroids. Thank God we stopped using DDT, which had all kinds of other horrible secondary infection problems. And now you're using these pyrethroids, which are in principle biodegradable and in principle shouldn't be damaging too much of other entomological fauna. You can in some areas you can use bed nets, especially when you have transmission by anophelines, which transmit malaria. So you kill basically 2 birds with 1 stone. You're controlling malaria, you're trying to prevent human vector contact, and you're also preventing human vector contact in filarial and other parasites as well. And finally, you can use something that is much more sophisticated and is used very much in dengue, chikungunya, and Zika, which is integrated vector management, which integrates the vector control itself, but it uses what we call combination for behavioral impact assessment. Basically, you try to change people's habits, and there's a lot of health education involved in this component. So it's a much more cumbersome, but very, very effective tool to try to control these diseases. The next slide, please. This is a very impressive slide of Brazil in Maceió, where they managed to treat only with one drug. That was the very first drug that you had. You're talking about 50, 60 years ago, the first drug you had to treat some filarial infections, including river blindness. And that was also used to treat elephantiasis, is what we call lymphatic filariasis. In some places, it was sadly called elephantiasis for some of the manifestations it causes. But here you see the graph basically the histogram in blue, how you upscaled the treatment with dialthogabamazine. That was one of the drugs and the only drug that was used in Maceió at the time between 2003 and 2018. And you see this impressive descent of microfilariamic patients from a very high level to practically zero in 2016. So this is how effective mass drug administration was already back then in Brazil. The next one. Environmental sanitation has also been critical in a lot of cities in developing countries, be this in Latin America, in the Caribbean, in Africa, Southeast Asia. It was very common to have these open drainage systems all over the place where people threw their garbage. Everything from the households went into these things that were highly polluted and were incredible breeding sites for mosquitoes. Well, fortunately, in the case of Brazil, in 2014, they intubated, they basically put these huge big tubes to basically close these channels, and that helped a lot because it definitely controlled quite a bit of the vector population density in that area. The next one. Brazil has done a fantastic job, I have to say, at this point, and a lot of the materials that I've been using in this slide come from two very, very important researchers, Gilberto Fontes and Eliana Roche, who for many, many years worked in Maceió and in Recife in the northeast of Brazil. And basically, I would say that they were among the most key scientists, parasitologists, behind the elimination of lymphatic filariasis in Brazil. So I really have to give credit to the two of them who were nice enough to give me and share with me the materials. I've been retired now for a while, so they had much more updated information than I had. So the second one is really probably the more interesting maybe for most of you, which is morbidity management and disability prevention. You basically abbreviate this as MMDP. And a lot of people got together to devise what is a very basic and simplistic, I would say, minimum package for morbidity management and disability prevention. Don't forget that this is a disease of poverty, that the majority of the people live either in rural settings where there's practically no access to healthcare or very little access to healthcare, or in cities where there's shanty towns, and even in these cities with shanty towns, there is really very, very poor access to healthcare. So the minimum package is when you have lymphedema management. Let me just make a little bracket here. Lymphedema is the worm causes, the adult worm, which is very large, causes first a mechanical blockade of the lymphatic system because it literally is so large that it blocks the flow of lymph in the lymphatic system. It also releases a number of products into the environment. I mean, like any other animal, including ourselves, it releases secretory and excretory materials into the surrounding media. And this causes for quite an important inflammation around it. And when the lymph exudes outside of the lymph vessels into the surrounding tissues, it produces what we call lymphedema, which affects primarily the lower limbs, but not just the lower limbs. We'll talk about that in a minute. But the pathology is basically because of this mechanical blockage and because of the materials that it releases into the surrounding tissues and the immune response that it elicits to try to combat the parasite. So the minimum package is lymphedema management, and this is basically home-based self-care consisting of daily washing with soap and clean water. This is something they can do in principle. Believe it or not, there's areas where they even don't have access to clean water, so this might even there be an issue. You ask them to elevate the limb because they get incredibly large limbs, enlargements with the lymphedema. And obviously, if you had the luxury of doing physical therapy, that would be another one. Extreme cases will wearing compression garments to reduce the swelling, air pressure, etc. But these are more sophisticated, and sometimes they don't even have the luxury of that. The next slide, please. The next one is something that is what we call, this is an almost impossible name, dermatolymphangiodadenitis, which is really caused by a secondary infection. Once you have this very severe lymphedema and you have fissures and you have growths in the tissue, you tend to get secondary infections with bacteria, which are usually streptococci or staphylococcal infections, which are very nasty. And these infections can only be treated with, well, they come up with a very painful flare-up that is really, really painful. You have to treat them immediately with antibiotics. You have to really do the hygiene, soap and water before you apply antifungal. Very often they get complicated with fungal infections, the likes of athlete foots. Athlete foots is caused by a fungi called trichophyton of different species. This can colonize these deep grooves in the patient's legs and can become infected. Hydrocele is another, it's the same as lymphedema, but in the scrotum area. And there you need a surgery. I don't want to get too much into a surgery, but you really have to it's a severe buildup of fluids inside the scrotum, and you have to relieve that extra fluid in order to be able to cut down on the amount of size, which is suffice. I mean, it's huge and keeps the patient really locked up and hidden in his home. Mass drug administration has to also touch upon these people. They really have to take the pills as well to reduce the need to reduce the load of adult worms and microfilariae. The next one, please. And this is what it looks like. So here you have the lymphedema of the legs, but it can also affect the arms, the breasts, the vulva. And when you have the most extreme case, chronic, a long time for this to develop, you will have these very enlarged parts of the limb, the lower limbs, the feet, the lower parts of the leg, huge, very thickened atrophic skin with these really clefts inside the skin, and that are very prone to become infected. They're very debilitating. They are really an issue for stigma. People usually hide in their homes. They're locked up in their homes under very uncomfortable positions. And so the next one. The next one is an older picture, but I just wanted to emphasize the issue of stigma. Stigma is really a problem with these people. There's a very young patient, must have been 10, 12 years old, in areas where they had very high densities of the parasite. So the higher the microfilarial density, the higher of the level you have adults living in the body, the more severe the damage is going to be. So these are the various forms of older pictures where the patient got affected. The next one, please. And I changed a little bit of the order. Well, the food for thought. I put it food for thought rather than challenges, because challenges puts people off. They think there's nothing you can do when you put challenges. But the reality is that you really have 25 neglected tropical diseases that affect, get this please, 1 billion people worldwide. Lymphatic filariasis is one of them. The current global goal to eliminate lymphatic filariasis is 2030 now. We pushed it from 2020 in 2000 to 2030 now recently. And this is when 80% of the endemic countries will have achieved the elimination goal as a public health problem. So far, 51 out of 72 countries have yet to reach that elimination goal. You have 2 of the 4 species of filaria that are zoonotic, which means that they also affect animals, and usually wild animals, which you cannot treat, are not susceptible to mass drug administration. So they will continually present a focus of infection for humans. Social mobilization is critical. It is a weakness, and it's absolutely necessary to boost compliance, because we're talking everybody needs to be treated. Vector control strategy, we already said, they're cumbersome. There's a cost associated with massive vector control strategies, but very often, if you can do it, and if you can piggyback on other programs that have vector control strategies, which is really the way we normally do it, it's one way of going that way. Digital technology, somebody talked yesterday quite extensively about digital technologies. Of course, we would like everybody to have mobile phones. This is not necessarily the case in some of the most remote areas, but mobile phones have been very, very useful in doing geospatial tools for mapping the disease transmission. You can go all the way to AI, telehealth, and others. So yes, if we had these, in most cases, you could have a tremendous potential. But I think one thing that has affected us the most is the withdrawal of external support, which threatens not just filariasis elimination, but thousands of millions of avoidable deaths, reversing decades of progress in global health. That's the current situation we have of a lot of the agencies that have had traditionally supported elimination programs. The next one. In residual morbidity, in 2024, the estimate of people having chronic disease manifestations by lymphatic filariasis still stood at 36 million people, 25 million people of whom had hydrocele, and over 15 million people had lymphedema. These are the official reported figures, and I remind you that these official reported figures are usually quite underestimated comparison to the real figures, but this is an estimate. I think enhanced morbidity management strategies, as we described them previously, are still missing in a lot of the areas. Integration of services is critical, not just for lymphatic filariasis control. It's a critical strategy for any developing countries in order to save on resources and optimize the resources. And you're seeing that there's big flaws and drawbacks in having integrated health systems, even in developed countries. Capacity building, obviously, you need to train people to comply. You need to train people in how best to take care of their legs and their lymphedema. And some of a very important point is the last one, but not least, migrants. Migrants are a big issue, especially when they're migrating from endemic areas into non-endemic areas, because that could reintroduce the disease into non-endemic areas or into previously eliminated area where lymphatic filariasis has been eliminated. We have a situation, for example, in Guyana. You remember the slide in Guyana, where 80% of the population is at risk. Well, Guyana is surrounded by Brazil, and Brazil has just declared elimination of lymphatic filariasis. So that's a continuous effort to keep surveillance up in border areas. The next one, please. The next one is, please don't read the whole thing. I just picked 3 countries out of the broad range of countries that still have lymphatic filariasis. India, because India is the 5th largest economy, and yet 62% of the global at-risk population, this is over 400 million people, are at risk of acquiring lymphatic filariasis in India. You still have a considerable number of lymphedema, 619,000, and still, relative to the total population, a fairly small amount of hydroceles that I have all the confidence that they will be treated in the next couple of years. But there's still a huge amount of population at risk in India. Nigeria is the 25th economy worldwide in terms of GDP, and has the highest burden of lymphatic filariasis in Africa. And of course, a lot of the same issues that affect some of the other countries, the lack of access to affordable disability-inclusive public health services, et cetera, and stigma in all of them is an issue in Nigeria as well. And one of the poorest countries, which is Democratic Republic of Congo, the DRC, contains the 2nd highest burden of lymphatic filariasis in Africa. And in addition to all the other problems that the others have, it has armed conflicts. So armed conflicts are a serious problem in those countries that are endemic, the wars, because you can imagine how difficult it is to get to these people in war-stricken areas. The next one, hopefully I'm getting towards the end. So the good news is that we do have a program to eliminate lymphatic filariasis that was basically consolidated in 2000 for the year 2030 to eliminate elephantiasis. We have now eliminated lymphatic filariasis in 21 countries out of 72 endemic countries. 16 countries additionally have stopped now MDA, Mass Drug Administration, and now are under surveillance. So that adds up to 21 countries. We've had in the past, these achievements are basically thanks to the international assistance that we've received in the past. That has been critical in reducing the disease burden. And we used to have 80 partners from all different walks of life in public and private sectors, academia, to international and development bilateral agencies. Unfortunately, this number, I don't know how much it has been reduced now because of what I mentioned before, but this is no longer the case. And then in 36 out of the 72 endemic countries. You've had the benefit of drug donations by the three companies, ivermectin by Merck, GlaxoSmithKline for the albendazole, and the Japanese company Eisai for diethylcarbamazine. And so these countries have had the benefits of the three drugs being used, with the added benefit of albendazole treating intestinal worms, which is also quite a serious problem in a lot of these, if not most of these developing countries. The next one. And I keep saying that might be the last. The next one, or there's not a last one? Ken? Was this the last one? I hope not. Or did we miss one?
Did I go past the slide, Doctor? I'm sorry.
The last one was basically, forget about the last one.
I should go back?
No, I mean the last slide. After this one.
Oh, okay. Nope, there's no more.
There's no more. Okay, then I missed the last slide in my last one. What I want to say, first of all, is that I think Rotary Club has had a tremendous job in concentrating its efforts in the health field on disabilities. Disability is much as neglected as all these neglected diseases that I spoke about and talked about. It's also very, very, I personally have a disability. Very interesting. I do not smell since I was born. The only problem of that was that, I mean, I don't envy the people that smell, because I was able to treat gangrenes without any problem, because I couldn't smell the stench of the gangrenes in diabetic patients that had secondary infections with myiasis with flies colonizing their legs. So since I don't smell, I was the only one among the residents, interns, that was able to treat patients and still talk to them and smile to them without smelling it. But the only time where this became a life-threatening situation is when I was studying medicine, and my wife, then girlfriend, walked into the kitchen where I was studying medicine. I was falling asleep and didn't notice that the gas stove was on and that I was basically committing sort of suicide without noticing it. And she came in, walked in just in the nick of time, and woke me up, opened all the windows, ventilated the room, and I came back to life. So this is what can happen when somebody who doesn't smell, and believe me, I have not met any other person that doesn't smell beyond the people that had COVID infection and temporarily suffer from anosmia. And then I have a brother that has Parkinson's disease. So I think 1 in 6 people worldwide have some form of disability. It's an enormous amount. It's really an enormous amount of people are affected by disabilities. So I really want to thank Rotary Club for their involvement in this. Very few other groups have focused on disability, including WHO, including all these other organizations. It's been, of course, kind of left to the end. That's why I was mentioning in one of my questions before, whether you as a group could really prepare a comprehensive roadmap. Maybe there is one that I'm not aware, but a roadmap that normally is prepared by WHO, but prepare a comprehensive roadmap, basically pooling all the expertise that you guys have in the field, on the ground, and in theoretical and digital and all the different areas, and your knowledge across the board. You have representation, and you mentioned, I don't know how many countries where you have clubs, Rotary clubs, including Merida, by the way. In Merida, my own city, I have 3 chapters of Rotary Club that unfortunately I don't see here in this presentation. So I would also suggest that possibly someone in the group make every possible effort to tap on those smaller groups in the smaller cities in the countries, because there you also have Rotary clubs sitting. And in our case here in Merida, they're donating wheelchairs. That's what they do here, one of the clubs at least. So my congratulations. I felt humble. I felt like crying in many of the presentations. It really touched me to the heart to see that there's so many people that are very much involved in this, affected and not affected, but very, very committed to the issue of disabilities. And with that, I hope I didn't put everybody to sleep, and I apologize for not being able to project the presentation myself. Thank you, Ken, for your support.
And Doctor, you didn't put us to sleep for sure. You were educating us, and I was enjoying learning more about all this. And I also need to thank you for the 40 years you put into working on this and working on the eradication of this and other diseases much appreciate what you've done for the world, and your suggestions. We certainly can take it up at our Rotary Club as a conversation afterwards. And Dr. Martha, who heads up our health pillar, we can certainly have her take a part in that. And the other thing too, I was thinking about too. So, bottom line is, this all starts with dirty water. Is that true? This all without dirty water, this wouldn't all be existence. Is that true?
Not necessarily. Those that are transmitted by QLEX are basically those that can be basically eradicated by putting in drainage system, proper drainage system. Other mosquitoes, but that's the bulk of the infection. So you would be doing a big intervention there if you did that. Mm-hmm. Other mosquitoes, such as Mansonia, for example, don't necessarily live in highly polluted, contaminated waters. There it's more difficult. So in some places, and usually it's those places where you have cleaner water and we have infections in animals, and where you have animal species, lymphatic filariasis, that can go over to the individuals. There you have to go more with health education, integration into health services, providing better health access to these people, and going to the community, going on the ground, and bringing this education, health education to the ground. But in most cases, fortunately, I think over 80% of the infections are caused by Wichura bancrofti and are transmitted by QLEX, and these are by and large breeding in these sites. Yes.
Oh, okay. So I mean, because when I look at your map and I see, well, there's some areas there's nothing, and some areas where it's terrible. So it has to come down to that situation. And I know Rotary, one of the things that we work on in Rotary is clean water. And, and polio is another thing that is passed on by dirty water too. So, God bless Rotary for doing that, trying to clean up the water systems in the world. And I mean, I'm from Colombia. I don't see anything in there in Colombia. But I do see dirty water here too. So, I mean.
Fortunately, Colombia doesn't have lymphatic filariasis, has not had it so far. We missed the last slide, unfortunately, which was to pay tribute to Brazil and the other countries that have eliminated it. I have to say, because they had an acknowledgement, WHO certifying the elimination of lymphatic filariasis. And that's a big exercise, because it takes a lot of post-mass drug administration surveillance to make sure, really sure, that you really don't have any transmission. So much credit to the countries that have eliminated it. I do have a question here. I don't know if I should answer it.
And the other thing I was thinking about, and I don't know, Sonia, if you're looking at the questions or not, that if there are any questions in there that we can go to. But the other thing I was thinking about, so somebody gets infected by a mosquito, how long before you even know that you've been infected? There's no early symptoms.
No. This mosquito takes a long time. It takes between 6 months, I think, an average, to get to from the point where it's bitten to the point where it reaches the lymphatic system. I mean, it takes quite a number of months to get there and become an adult. It takes, again, a couple of months before it develops into an adult worm. And once you have that, then it's up to 8 years that an adult worm can live in that location. Of course, people become reinfected, and that increases the worm burden inside the host. So yeah, it takes a while. Normally, the test that was developed, which is the antigen detection test, is a rapid test. That has also simplified the diagnosis of it. It's a rapid test that you don't have to take the samples in the middle of the night like you would do with a normal, traditional, older test. You can do the test any time of the day, and that's a very, very rapid test that can pick up the infection very well.
Okay. Sonia, are there any questions in the Q&A?
There was a question.
Yes.
I'm reading one question. I think it's from Martha, but why don't let me hear the questions, and then I'll get to these questions last. Is that okay with you?
You're good at that, John. Thank you.
Here we go. So the next, somebody read their question.
Is there a question, Sonia?
Yeah, there is. Does Rotary Club fund knowledge translation activities of a PhD studies related to people with disabilities, which is not really directed to the presentation, but in case you do have an answer?
I haven't seen, and believe me, I've worked with Lions clubs, I worked with pharmaceuticals, I worked with doctors I worked with a lot of individuals in this, and in the case of Rotary clubs, always with disabilities, wheelchairs, and other measures. But I have not seen postdocs, that is at the level of masters, or specialties, residencies, or PhD program financed by Rotary. the Swiss Tropical Public Health, Swiss Tropical Institute in Basel, of which I'm the external review chair of that institute, has access to some of the agencies that provide stipends and scholarships for masters and PhDs. So you really have to take a look at some of these agencies, development agencies, DFID for the UK, CEDA and NORAD for the Scandinavians, DAAD for German development agencies, maybe some of the banks, the German Credit Bank, which is WWF, some WWF, et cetera, et cetera. So there's many different agencies that actually develop and provide support for master's and PhD programs. And I think one of the best institutes that actually does that is Swiss Tropical Institute in Basel, but also the London School of Hygiene and Tropical Medicine, or the Liverpool School of Tropical Medicine is also a very, very important area where they do a lot of research on lymphatic filariasis and other parasites.
Okay, thank you for that. I'm sure we'll be able to share this presentation with the member who's asked this question, and they will be able to get further assistance. There's another question here that says, what is the prevalence of the filariasis in Dominican Republic, and how is the public health system addressing it?
We said that they had, if you can go back, there was a slide where you had 30, wait a second, was it 30 or, I remember by heart, but 30,000, I think they were estimated 30,000, which is about 8% of the population. It's a very small percentage of the population, which is strange because it's next to Haiti, that has a very, there they have an 80% of the population at risk and a very hard number of 780,000 people infected. So Dominican Republic has a problem. Normally, you start the problem because it affects the skin first. That's the point of entry. You get the lymphedema and you start getting maybe skin infections that are usually treated by a dermatologist. They mean well, but they very often miss the causative agent. They think it's something else. There's a dermatological institute in Dominican Republic in Santo Domingo that has been working on dermatological problems for years and years and years and years. They are mainly specialized in Hansen's disease, which is leprosy, but they come across also lymphatic filariasis patients. When they have skin manifestations, they usually pick it up. Now, the Dominican Republic public health system is as almost all the health systems throughout Latin America. Let me start with the best. The best is Brazil. They have what they call SUS, the Sistema Único de Saúde, which is a unique health system in Brazil. They treat pretty much everybody, and they're spread out throughout the country. So they have a fairly good system in place that will even operate hydrocele and maybe even elephantiasis, where you have these very thick skin and atrophied skin that might even reduce the fibrosis in some of these cases. So Brazil is really the gold standard. Mexico is a good country, but we don't have lymphatic filariasis. The Dominican Republic has a relatively weak system, I have to say. So the cost of treating hydrocele in the Dominican Republic is extremely high, is because it usually goes to the private healthcare system. It would, in principle, be very cheap. You could treat it for $16 in the public health system. But if you treat it in a private system, it may go up to $3,000 a surgery for hydrocele. So Dominican Republic, depending on where you end up, if it's in the public system, you may be postponed and pushed, and you may have to wait a long time to be treated. Hydrocele surgeries may not be their top priorities. And if you get yourself a private doctor, in the worst case scenarios, they will not be able to do a proper surgery. In the best case scenarios, they might do a good surgery and they will cover you something in the order of between $1,500 and $3,000. That's the situation in the Dominican Republic.
So, and this may be a dumb question, but so obviously it's going, if I come down with this disease, it's going to impact my quality of life, but does it shorten your lifespan too? Are you going to die from it?
Definitely shortens your lifespan, especially in areas where there's a big stigma and where you're less likely to seek medical attention. You can imagine if you have a hydrocele or a lymphedema or even an elephantiasis foot, to go walk on the street, go to seek medical attention. Very often you have to take a bus You have to ride a donkey, a mule, a bus, and then end up in a hospital. You don't want to be seen. You don't want to be exposed. People are when they look at a case of elephantiasis or hydrocele, they get put off immediately. I mean, they're very afraid of that. People watching that are very nervous. Very difficult to hide. So somebody that is that sick is usually kept at home. They usually try to get a witch doctor, or may want to get a doctor that happens to be in the village, in the pharmacy, or even the pharmacist. Very often it's a pharmacy and not doctors that are not available, but the pharmacy that will provide the first aid and the first help. So yeah, that reduces, because of the secondary infection and everything else, it affects very seriously the quality of life, and it affects ultimately the survival rates of these people. Life expectancy of these people.
Wow. Again, the lives that you've changed with the work you've done over the last 40 years, we can't thank you enough on that. We really can't. God bless you for that.
Thank you very much.
I don't know if there's any other questions. I know I've learned a lot from in the last hour, and that I didn't know before. And Dr. Martha has popped in here. Dr. Martha.
There is another question. I belong to the NTD club here in Ghana in the University of Health and Allied Science. We would be glad to have the full support of Rotary for visibility and more advocacy, since I am a disability and social inclusion advocate. My name is Giti from Ghana. That is one message. And I want to tell something to Dr. Ehrenberg. Thank you, Dr. Ehrenberg, for your interesting presentation and for your active participation, asking questions during the Health Summit. My question, I have actually two questions, one question and one comment. The final outcome of this infection is a severe disability that leaves the patient unable to walk and work. So are there any problems to help these victims of lymphatic filariasis?
Yes. So the question, depending on where you are, yes. In Brazil, where they've had a very, very successful elimination program, they've managed to get, and basically the bulk of the problem in Brazil was in two cities in the Northeast, Maceió and Recife, which is really a very, very large city. I believe it's the capital of the state of Pernambuco. So it's a very large city. And so clearly in those two areas, they had better access to healthcare facilities. And there were a couple of clinicians and researchers that specialize in lymphatic filariasis in those two cities. And they actually refined the techniques to operate patients with hydrocele and with other complications. So in Brazil, it's pretty much a done deal where they've actually managed to do this. Gambia in Africa is the only country that has not done any mass drug administration at all. So if you happen to have any Rotarians in Gambia, that would be a country that you should really look into, because that's the only country missing in starting mass drug administration in the world. I think in India, it's the same situation similar to Brazil. India has very sophisticated health facilities. So you might have people that might have access to the private sector and pay a large amount of money, but you might even have people that don't have that and have access to public health system. And in India, in some areas, especially endemic areas, I would assume that's one area where I didn't go and see on the spot, in the field, on the ground, whether their health facilities had the same capacity as they had in the Brazilian ones to successfully operate hydrocele and, for example, reduce the fibrous tissues of the patient, or even provide, the physiotherapy that you really need for some of these patients. These patients with the extreme cases of lymphedema and elephantiasis really have a very difficult time to walk. They definitely have a difficult time. So they remain seated, which is really not good for them because they don't usually put their legs up, and they don't have any compression, things to help the edema, the lymphedema. So in those cases, so it depends very much on where you are. Would be the answer to your question.
Thank you very much. And one comment. I would like you to add to the list of good news that what you told me about the children, the 4-year-old children, that if you treat those children, then they are not going to be part of these 36 million of victims of lymphatic filariasis, because then the disease is reversible.
Absolutely. And remember that there are 36 countries I mentioned that get the treatment for free because the 3 companies donate the drug. So it's a question of those countries that do not have that benefit to negotiate with the companies. And this you normally do through WHO offices. They have a neglected diseases, tropical diseases department, and normally you do it through them to apply so that that country that does not have the benefit of IDA, which is ivermectin, diethylcarbamazine, and albendazole, to actually have these companies do a memorandum of understanding with WHO to treat these countries also with these 3 drugs that have the side benefit of treating also intestinal worms.
Great. Thank you, Doctor, very much. We'll hopefully do something again with you in the future. It's been a pleasure working with you.
Ken. It's been a pleasure with you too. And Martha and everybody else, again, my deepest, deepest appreciation for you guys. You're doing a good job.
Thank you. Take care.